One of the most important aspects of an occlusal analysis is getting really clean models. We want to make sure that we capture not only the occlusal surfaces of the teeth, we need the free gingival margins all the way around buccal and lingual, and we want to capture the land areas well above the teeth. And it's really important for assistants to be able to start looking at their impressions and making sure they got everything that the doctor needs. It seems like overkill. I can remember in dental school working with a prosthodontist who just beat on me my first semester, taking alginate after alginate after alginate, making sure I captured all these land areas. But what I've come to learn, particularly when you start doing diagnostic wax-ups and you start making provisional matrices and prep reduction guides, that all these things that we make for restorative dentistry, particularly with regards to provisional restorations, the matrices will seat on the tissue. And if we don't capture those areas, then we have major problems trying to make provisionals that work properly, prep reduction guides so we can see that we've done enough reduction. And so, it's just important. One of the things that Dr. Dawson has taught us over the years is that the earlier we make a mistake in this process, the further we're going to be off at the end. So bad diagnostic impressions lead to bad wax-ups, bad temporaries, and then we have no way to communicate to the lab, and we end up miles off. And all that leads to is just increased remakes, decreased productivity, and decreased efficiency. So all these little things will lead directly to the bottom lines of your practices. So let's just take some time and make sure we're doing this right. Now, one of the things I want to show you that I'm excited about is that one of our faculty member, Dr. Ian Buckle, who's in just below Liverpool, on the Wirral, if you will, in northern England, taught me this technique using a putty and a wash for our diagnostic impressions. And so we actually left alginate and started doing polyvinyl materials, and we found that Heraeus' Flex Time Putty, with where we stand right now, is really an optimum material for this. So what I want to do is just show again how Mariah does this in our practice and how we get clean impressions, and really show you how easy this is. The first thing we're going to do is just begin by using an adhesive on these trays. And so, just a plastic tray works very, very nicely. Just be sure, there's lots of different adhesives out here. One of the mistakes we occasionally see is an assistant or a doctor using an alginate adhesive for a polyvinyl. So this is an adhesive you're going to use just like you would use for a crown and bridge type impression. Some of you are probably worried about the cost of this involved compared to alginate, and there is some additional cost in terms of using this material. But here again, one of the things that we're recommending, particularly on the cases that are more complicated, is to have 2 sets of models. And so the great thing about a polyvinyl is it can be poured multiple times. And so there's no need to have the additional chair time of taking 4 impressions. You can just take 2 really good impressions, and I think you're going to find out in the end you're going to come out ahead. You're also going to see with this technique, because the putty displaces tissue so well, that you really get very well extended impressions, and you're not going to have to remake or retake impressions very often following this technique. Just make sure that when you apply this that you let it dry. Using a little stream of air can be very, very helpful. You just don't want to see any movement of the adhesive on the tray before you start mixing your material. Next thing we're going to do is mix the material, and there's a base and catalyst. The most important thing with all of these putties is to mix it with your fingertips and keep it moving. We have different colors so that you can tell when this material is properly adapted. So keep it mixing with your fingertips so you no longer see streaks, and that it becomes one uniform color. And then you're going to kind of orient it into like a little hot dog, and you can pick up the tray and get it seated. Now we're going to be doing the mandibular cast or the mandibular impression first. And so now she can go ahead and come to the mouth with it. So again, what's interesting about this technique is our ability to go ahead and seat this. And we're going to wait maybe 10 or 15 seconds, but we don't let this material set up. If you will, we're creating a custom tray. And the density of this putty will displace the tissues really, really nicely, so you'll get all those land areas on the buccal and lingual. And then when Mariah feels like that we've kind of got that, not initial set, but that we've got a nice adaptation, what she's going to do is pull this out of the patient's mouth. And again, go back to the bracket table. And she's going to go ahead and squirt a wash of polyvinyl material, a polyvinyl wash, right into it. Now what she likes to do first is just kind of create a trough for where the teeth would be. She can also pinch this material if she feels that it hasn't been properly extended. But this is that customization that works so nice, because you're literally creating just a little custom tray for our preliminary impression. So just the wash of polyvinyl material goes in. Notice how she's getting it around the land areas. Got lots of working time here, so we don't have to panic. Now she's going to go back to the mouth now. And the first thing we've got to do, let that tray sit there. She's just going to dry the teeth. Because remember, with polyvinyl materials, that you just don't want to have fluid. And this is where we get the real accuracy on the occlusal surfaces. Because she's just going to dry it, leave a little 2x2 sitting there right on top of the teeth. Little saliva ejector in there. And now she can get the tray. Come back to the mouth. And when this goes in, this is what's slick, is that the putty and the wash is even going to displace the tissues even a little bit further. You get some hydrostatic pressure going on the teeth. And all this sets up at one time. So, this process is going to take maybe 3 or 4 minutes, but what I think you'll find is it leads to unbelievably detailed, accurate diagnostic impressions. And so what I would tell you is that if your alginates, or if you're finding that the team is having trouble getting either opposings or your diagnostic impressions as accurately as you would like, consider using the flex time putty technique as we've shown you, as Dr. Buckle showed me, and we've really been pleased with its results. Okay, what we're going to see with this material is that the green stuff actually will set up first. The wash material sets up first. Set time is about 2.5 to 3 minutes. We really recommend that you do it by feel, because temperature of the operatories is going to affect that. But use your thumb and feel it when it's nice and firm. Then you can remove it with a nice little yank. All right, now for the maxillary impression, we're dealing with basically the same thing. We're going to get our putty first, and again, go through the same process of mixing it in your fingers. The one thing that I would suggest is that you want to make sure you want to get the palate here, so you might be using just a little bit more material, but you want to make sure you get the teeth as well as the entire palate, all the way back to the hamular notches, and then all the way up the land area to the mucobuccal fold there. So you need to have enough material. But notice how she's mixing it in her fingers to that uniform color. And then she's going to roll it up. And again, in this one, not so much of a donut shape, but getting it to go uniformly across the entire width of that maxillary tray. So now we're going to go ahead, just like before, seat this in the patient's mouth. Again, from this view, for the upper, you're going to be standing behind the patient. And go ahead and seat this straight up, maybe a little bit more towards the second molars first. But again, this stuff's fairly thick, so you're going to have to give it a good seating, pull the lip over it. You can actually kind of push from the outside and feel that material being extended all the way up. And again, all we're trying to do here is create that custom tray. We'll wait our 20 to 30 seconds for it to get flow where it needs to flow. And we can pull that right out of the patient's mouth. And again, the same thing. She will create a little sleuth wave for the wash of the polyvinyl material. She pinches any area that she wants to extend a little further. Maybe peels off area that's extending back too far. Patients appreciate that in the back of the throat. And then she can pick up her wash of polyvinyl. And again, just put it where the teeth are. Again, make sure you get a little bit up so you get some flow up into the vestibule there. And then we can go back to the patient's mouth. And then you're going to seat this just like you would any impression. Dry the teeth first. It's really important because if you have fluid on those occlusal surfaces, you're going to end up with bubbles. Probably even more important with this material than with an alginate. So get the teeth dry just like you would if you were doing a final impression. Sometimes you feel like you've got a rush here, but you've got a little more working time than you think. Pull the cotton out. And then we're going to go ahead and seat this tray. And lift that lip up. Again, border molding, pushing that material. You get unbelievable extension. And then we're just going to wait our 2.5 to 3 minutes for setting. Again, we're going to be checking with not just time, but with our fingers, and remembering that it's the putty that tends to set up last. Okay, so after the allotted time, here again, this material is firm, so it may take a little bit of time to remove it. One thing to be careful of is that if you have patients with older bridge work that has high water ponics, you want to make sure you block that out with some sort of wax so that we don't engage those undercuts. All right, so when we analyze our maxillary impression, what I want to see, you can see all the way back to our hamular notches back here. I've got my border buccally well extended above our free gingival margin. I've got all the palatal tissue here. And that's really want to see. Make sure that all the teeth are captured, that we've got our free gingival margin on the facial and lingual surface, and then we've got good soft tissue, good land areas well above the free gingival margin, buccally and lingually. So that is a really nice maxillary diagnostic model. You look at the mandibular model, and it's the same thing. We want to make sure that we've got free gingival margin buccally, we got free gingival margin lingually, we've got land areas on the buccal, we got land areas in the lingual, and we're well extended past the most distal molar, and we've even captured the retromolar pads back here. So if we can do this day in and day out on our diagnostic impressions, we're going to have really good casts for a quality occlusal analysis. We'll have really good casts for opposing impressions, and this will be go well with a practice that's trying to achieve optimum quality, predictability, efficiency, and increased profitability.